Voi spune câteva cuvinte în limba română. De fapt, e o audiență internațională. Avem onoarea să-l avem printre noi pe profesorul Zsolt Garami de la Centrul de Vechi din Houston, care domnul profesor Zsolt Garami este un renume și național în Statele Unite, dar și internațional în ultrasunete intracranian, în procedura de Doppler transcranial. Este un nume cunoscut, cu prelegeri și cu activitate și în cadrul armatei. O să vă prezinte domnul profesor detalii despre această tematică. Este o tematică foarte specială și specializată, o specializare în sine, care necesită experiență, aparatură. Eu când vorbesc de Houston, îmi aduc aminte de NASA, deci tehnica de acolo este binevenită. And now I present in English Professor Zsolt Garami from Houston the big center, cardiac and vascular center. He is director of ultrasound lab in Houston, and it's a very known name, and it's worldwide began in this field in Transcranial Doppler. He is certified in Europe, in USA too, and it's an honor, professor, to be in this lab. This lab was opened 2 weeks ago with the university, Western University Goldish, Vasile Goldish from Arad, by participation, direct participation of our rector of university, Professor Coralia Cotoraci. And this lab, in fact, it's joined between clinical practice here near this lab, the clinical hospital of the university, and university teaching and training for surgical practice. And not only for surgical practice, we have here ultrasound devices for practice in ultrasound techniques. And I stop here my short presentation. Please, Professor, it's an honor for us to be here in our small lab, but this lab we will constate this. It's connected in Word, and perhaps if our IT department can contact with another lab close of your heart, we will take this. Please, Professor, present yourself and your topic.
Thank you. Do you need to, Attila, do you need to present anybody, or this is we good to go? So we're good to go. Yes. Welcome everybody, and I'm glad to be here. What I'm going to do is I'm going to show you some slides. I'm going to double the camera and the slides go this way. So first, okay, hold on. I need to go back to my first slide. So thank you for the invitation. So what we're trying to do in ultrasound, the motivation is this is a talk for students and any specialty. I'm a radiologist by training, but I wanted to be a neurologist one day. This is when I started to use Transcranial Doppler as a student because I was looking for a thesis work. And when I went to United States, I was doing a CT research. And one day they asked me, hey, who knows how to do ultrasound? And this is how I ended up becoming an ultrasound guy, and I'm board certified in radiology, but I'm working in a cardiovascular center. And it's very interesting how the cardiovascular center really using a lot of ultrasound for vascular surgery, cardiac surgery, but also we're using for neuro care, neuro ICU, cardiology for PF4 detection. And what I brought my TCD machine. It's arrived in one piece, so not just a lecture, but we'll have the option to do some hands-on training with this ultrasound today. And how the Transcranial Doppler, they developed it in '82, so this is not a new technology. In 1982, they figured out with a 2 megahertz tiny ultrasound probe, you can send the signal in through the bone and reflect the movement of the red blood cells, and this is how you can tell the speed of the blood flow. And we're using a bunch of different approaches, so easy to do through the eye because not too much bone. Transtemporal, you feel there's a tiny dent in front of your ear. That is where the bone is a little bit thinner, so the ultrasound can go through. You can put through the foramen magnum, and the submandibular area is right here, so the angle of the jaw. And these are different blood vessels, but again, it's like a coin. And I have the 3D print on the table. You can kind of pass around. That is a real size of the circle of Willis. So when you look at the 3D printout, this is the size of our blood vessels. And again, this is just kind of easier to show you where the ultrasound is going to check each of these blood vessels. So it's really easy to go through the MCA, you see the ACA, the PCA, and from back of the neck you will see the vertical and the basilar. And when you go through all those different blood vessels, you need to go back to your anatomy class because they told us that, oh, there's no branches of the ICA. So the internal carotid artery has a bunch of branches, not the ophthalmic is the first one, but the ophthalmic is marking what the intracranial space starts with. But this is where we are mapping. I'm just not going to give you too much of the anatomy talks, but show you some samples. In the United States, we're dividing into 4 different studies. So regular, just a diagnostic study, meaning that you're looking for any narrowing or blockage in the blood vessels. Vasomotor reactivity, it's a really simple test. You ask the person to hold the breath, and during the breath hold, for the lack of oxygen and the CO2 buildup, changing the resistance of the vessel. So behind is stenosis, you want to see how much collaterals are they, and this is how you can test it with the vasomotor reactivity. Emboli detection is one of our favorite because with irregular heartbeat or any tiny clots, you can pick up these tiny microannual signals with the ultrasound screen. So what you see is the ultrasound reflects, and there's something else red in the red blood cells traveling in your ultrasound in your bloodstream that will record with a high pitch, and you will see like a white line on it. And finally, I will show you how to detect the PFO, the patent foramen ovale, like a hole in the heart. So all these different approaches, and again, if you like physics and you want to play ultrasound, this is your regular piano. So you can see that you're not at the 2 megahertz yet. You need to have 2.5 long piano keys to really start to play the ultrasound. And why is ultrasound? Because you don't hear it anymore. So this is where the 2 megahertz really coming from. When you use the other ultrasound machine which generate pictures, usually that's also 1 to 5 megahertz. So this is what if you look at the piano key, this is where we start to see and hear the ultrasound, I guess, by the image. And this is just one picture of the ultrasound, what it generates. So the Transcranial Doppler has these 2 parts. So the upper part, it's called M mode, motion mode. Ultrasound goes in, coming towards your probe is red, going away is blue. So this is the number 1. If you're colorblind, give up ultrasound. Because you really need to see the red and blue. If you cannot differentiate red and blue, find some other specialty, because that is how it works. And then you're selecting by this line where you're going to listen to and see the speed of the velocities. You guys can have a seat here too, on those. So what you do is by measuring the blood flow, you can tell between your measurement point and a heart, there's no obstruction because this upslope is present. So think about the heart is pumping out the blood flow, and if you have a blockage or narrowing anywhere, that will result that systolic upslope will be delayed. So that's the delayed upslope that you will pick up if you have any blockage. The other interesting thing is that you think about this brain ultrasound as a art line for your brain. And when you look at this is the aortic valve closure. Cool. It's really interesting when you look at this, how the systole is really short and your diastole is very long. But you have another notch here. So the other notch is really when your muscle in your blood vessel dilates a little bit and it's pushing again almost like a second pulse, your blood flow towards distal. And when you get hypertension, that's going to disappear. So it's really interesting how many information is in that waveform. Right now we're just using a mean flow velocity, and we'll give you the examples of how these waveforms are different. But again, the number one, systolic upstroke present or not. If your systolic upstroke is there, then there's no blockage between your measurement point and the heart. So on this picture, if your probe is in the temporal bone, by the depth, 30 to 70, so this distance, you see the middle cerebral artery coming towards your probe. At the depth of 50, you are detecting the speed, and the depth of 50 is somewhere right in the middle of the middle cerebral artery. Cool? And if you guys have any questions, just stop me. It's like, hey, can you repeat that? Or just go ahead and ask questions, okay? And for the online people, just put your questions in the chat. This picture is really fancy because I think when you look at any angios on the lateral view, you see the vertebral is turning around the skull entrance. So when you do an MR, it's neck and brain, but at the skull entrance, you don't have any images. So that's why it's pretty cool that the ultrasound is able to give you the through image of the intra and extracranial blood flow as well. And why we like ultrasound? It's objective. EEG, say, slow, fast, all that. Ultrasound give you two numbers. Objectively give you a number of the mean flow velocity and give you a number of the pulsatility index. This pulsatility index is really tells you how resistance build up in the vessels. So high pulsatility index, that's high resistance. Low pulsatility is nice, and this is how it looks like. Your low resistance, when it's high resistance and your PI is up, these are the chronic hypertension or increased intracranial pressures linked to shut down your diastolic flow. Cool? So in diastole, you don't see flow. Brain doesn't like it. Brain wants to see a flow like this. And around our body, there's few organs who has low resistance flow. Spleen, kidneys, coronaries, brain, and after you ate, your gastric. So after you ate, you need to have a nice low resistance bed, take the food away, but it's really limited pieces of the blood, of the body which has low resistance blood flow. The extremities, they have high resistance because you don't have diastolic flow when you go down to the arm or to the leg. And when the low resistance is very low, that also shows disease. For example, AVM. I will show you in AVM when you have low resistance bed with the artery and the vein, that's extremely low resistance, that's abnormal. Cool? This is how easy to say this is normal, this is abnormal. And this is an example of a 40-year-old gentleman who had a stroke, and not just had a stroke, but you can tell that there's obstruction on this side. So this is the power of this ultrasound, that you're comparing the flow from right to left, but also by, you can tell this blunted signal that you don't have your systolic upstroke, so you have a blockage, but also with this blunted waveform tells you that you have really poor collaterals. So even though you have choroidal occlusion, you would expect the other collaterals to feed the rest of the brain, and you don't see that. So this is almost like non-pulsatile flow, almost like venous flow looks like on that artery. This is another example of high resistance and low resistance. High resistance because this is feeding the eye. Cool? Low resistance feeding the brain. This is how easy to say You don't want to see high resistance flow in the brain. You only want to see low resistance flow in the brain. And when we do the submandibular flow pattern, you can see that your probe is showing a flow away from you, so now it's going to be a blue signal. And this is important when you have subarachnoid hemorrhage and you're looking for vasospasm in the brain after a car accident, or if you have, again, subarachnoid bleeding. And we monitor up to 2-3 weeks to make sure that they go into vasospasm, because that can trigger a secondary stroke. So vasospasm, you want to see what's the intracranial divided the extracranial flow. So there's a really cool number that you can tell what's the flow intracranial and extracranially, and that's how you can really use these numbers. So an example again, when you have a normal flow in the, through the eye, high resistance. If you have a blockage of the carotid, there's no more flow towards the eye, becomes reversed. Again, this is why it's good to know the colors. So this is not just changed red to blue, but you notice that became low resistance and continuous. So when you go back and you see this is intermittent in diastole, not much flow, now became a continuous blue signal. So it's going away from my probe and going to feed the brain, not going to feed the eye. So it's very interesting. The eye will still find a way to get some flow into eyes despite the carotid occlusion. So this is one of the collateral pathways to get some flow to the brain if you have poor collaterals through the eye arteries. Gorgeous picture. This is what it tells you, that midline of the skull is somewhere around 7 centimeters, 775 millimeters. So this side, red, blue, is one side, and you see the old contralateral side. So this is how you go through the, your probe is here, and you are going to see the middle cerebral artery, anterior cerebral artery blue, but you cross the midline, and you're going to see the contralateral ACA as red, and the contralateral MC as blue. Cool? So because you're going through one side, that's why it's a different color. Got it? Please tell me that you understand that part, please. So just think about that, and because your probe is on this side, this is red-blue, but you cross the midline. That's why it's two different colors, because your probe is still going from the other side. So that's why we call it a contralateral side, going to have a different color. This is just a bigger skull. So here your midline is about 8. So maybe guys have a bigger skull, ladies have a smaller skull. Yeah, but after the age of 12, 14, our skull is not changing too much. So again, the kid's skull compared to adult is kind of similar. And this is just shows you trying to make a posterior circulation probe, that when you point posteriorly, then this is when you're going to get the PCA. And the PCA is again, you're just kind of angling the probe posteriorly and able to get the PCAs. And the PCA is blue, going away from you. So the PCA is this area, a little bit of red because the PCA is turning. So when it comes on the tip of the basilar, the PCA is making a turn, sharp turn, and this is why you see a red and blue signals. So finally, the posterior circulation one more time. Everything is blue because your probe is in the back and the signal going away from your hand. And when you see a red signal, these are the branches. So when you go back and you see it on angio, these red signals, so these are the branches of the vessels, and these are the smaller signatures. So that's why everything is blue, but a different branch coming off a different direction. That's why it's a red signal. Cool? I am going to stop here and show you some cool cases so you understand why this PCD is really fun. So this is my first ever MC occlusion I detected. So what you see here is that there's no MCA signal, no red at all. Then you have an intermittent signal, so really high resistance. So that's the signature of an occluded vessel. So basically the flow is not low resistance, but trying to go through that clot. This is how you can detect an MC occlusion. And how we picked this up, that we had the ER service that when the patient comes in to have a CT scan with acute stroke, this is when we will do these ultrasounds, because we're able to see where the clot is. That time we didn't have CTA, so no CTA took over for all that, but again, ultrasound can detect these occlusion site. And during the TPA, you see the recanalization. So that is beautiful. You can monitor the flow recanalization during the TPA and the thrombolysis. And sometimes, again, SETI goes and reoccludes. These are the patient can go to thrombectomies. When the speed really high, so this is 300 and 150. A normal speed for the adult brain is anywhere between 20 to 80 miles per hour, kilometer per hour, almost your car speed. So it's really interesting that 20 to 80, and when this speed is somewhere like 200, that's the narrowed vessel. So this is how you will pick up a stenosis. And when, again, one of the branches occluding, then you have no diastolic flow, and lots of flow going to the other branch. That's how you see the direct occlusion and the indirect sign of the occlusions. I want you to watch this with me. So there's a catheter in the innominate artery, and I'm going to dilate this with a balloon, and this is the bad signal with the embolization, and a balloon, the stenting of that area immediately will improve. And that's the real way of really showing the power of ultrasound, that you see the improvement immediately. Not like a month later that you know that you did a procedure and the patient tells you, yeah, I feel better. No, what you see here, that you saw at the beginning, there was a triangle-shaped waveform. No, this is a normal waveform. It tells you that your surgery was successful, yes. When you look at angio, your stent is open, but I think it's the brain tells you that, yeah, whatever you did, you put a stent there, you improve the flow in the brain, and that's truly our end result. This is just one of those funny cases. I did a ultrasound through the eye, and then we learned that on the CT, this is how it looks like if you have artificial eyeball. And the ultrasound can get through an artificial eyeball. So I hope you guys are not going to run into artificial eyeballs as I did, but this is how it looks like. And another interesting story, what I like about therapeutic CTs, then when you have a stroke patient coming in, you see how the lens is deviating. So that means the patient is looking at the stride of the stroke. It means that this is a left MCA stroke. Sometimes you have these indirect signs, not to see in the tissue where is the stroke, but again, the eye deviates to the side where the stroke is. Especially in the acute phase, the first 6 hours, you're going to see the lens deviating, because the patient eyes is closed, laying down in the CT scan, so that's why you know that this is, again, one of those cool observation, how it's kind of confirming your findings. The other thing you see through the eye is a stenosis here, and when you go through the eye, you're able to pick up that middle cerebral stenosis as well. 32-year-old patient. So this is another sad thing that I started to notice younger and younger stroke patient coming into our clinic. This is a 32-year-old lady with 90% stenosis in the middle cerebral artery. That 90% is a moya, and almost you can see a new vessel revascularization around the middle cerebral artery. So this is again an AP view, carotid, left carotid, ACA, this is your MCA, and the flow is extremely high. Your end diastole is 200. So when you know that your normal speed is supposed to be 20 to 80, and you see a speed of 200, then you know it's a really high velocity. So we stent it, and when you're stenting it, you see immediately the improvement and your velocity goes down. So that's the nice correlation, how you compare the angiographic finding and your ultrasound give you your baseline, because you're not going to repeat angios, but you can repeat ultrasound really easily and follow this patient. 2 months later, we found another stenosis. Inside the stent, you see the yellow line? See the struts, the black dots? This is the two ends of the stent. 90% restenosis. 2 months. So this is where you put another stent in it, inside the stent. And we're talking about 2-3 millimeter size vessels here. See this guy? That's the middle cerebral artery. And that's when you're looking at real size. And I think another 3 months, this was the next stenosis. But right now she's stable, and this is like 10 years out. But this is what I feel that we have younger and younger stroke patients coming to see us. And this is when you see like age of 32 to face a 90% middle cerebral artery stenosis. That's quite scary. This is, I would say, the high-end ultrasound. What you see here is an MR and ultrasound, and you see the stent. This is the same case. Watch this. Now I'm fusing images, and I'm showing the ultrasound over the MR. How cool is that? Have you guys seen something like this? Thank you for coming. See? This is why you're here. So when you're arguing about between two imaging modality, which is better, just put them together and say, hey, MR is useless because the metal artifact, you wouldn't be able to see the flow. But ultrasound comes, and with the ultrasound able to show you the flow inside that metal artifact, and you can show the stent is open. Yeah, a little bit of dark, but I guess you guys can see it. So, and this is the ultrasound beam. See, that shows you around the 3D MR structure was the ultrasound beam. It shows you in the brain. This is the same. So previous was the G. This is the Philips machine. So every ultrasound machine, you just need to figure out those buttons. Sometimes you don't know what the button means. This is called a volume navigation. Volume navigation because of the 3D volume structure. And you need to have a tiny magnetic field where your probe is. So that's what feeling where your probe is located. And with the stent, you can see the flow in it. This is one of my favorite. So this is the files of my favorite cases, and I would say this is one of the best. ECIC bypass, really hard when you have no other option and you have a carotid occluded. You hook up the superficial temporal artery to the brain. So the superficial temporal, which runs here underneath your skin, you hook it and doing a bypass to the middle cerebral artery. So this is what you see here. And again, so much easier to do it with ultrasound rather than CT or something else. So this is where, So, the story here, we were looking for 50% carotid stenosis. Cross-section view, there's two carotid machines, you're going to do your own carotid. And on the MR, shows you this whole white area. And you wouldn't think, based on the ultrasound, that this whole dark is part of your carotid. So some of the plaques are not protruding when they're growing into your lumen, but they are growing outside the wall. So this is another new fancy way of, look at what's outside the vessel wall, not just what's inside. When you say, hey, there's another stroke with 50% or no significant stenosis, but you may have a ruptured plaque which is outside the vessel wall, not inside the vessel wall. So this is quite interesting.
Do you feel anything?
Yes.
What do you feel?
Just dizzy or head getting lighter and lighter and lighter. Yeah.
Put your arm down.
I need to show you this one more time. So pay attention to this waveform. So he's lifting his arm up, and this waveform is disappearing.
Do you feel anything?
Yes.
What do you feel?
Just dizzy or head getting lighter and lighter and lighter. Yeah.
Put your arm down.
What just happened here, that you're linking the patient's symptom to a body motion that is provoking his symptom. Cool? So what's your treatment? Don't lift your arm up. But when he goes to the kitchen and he wants to grab something from a kitchen or grab a glass or something, he always reported that anytime I'm lifting my arm up, here's my dizzy spell. So this was the PCA monitoring, and this is quite, I would say, a significant change on the waveform. And you can see it becomes non-pulsatile. So I'm monitoring the PC on this case. And why I like the posterior circulation? Because the posterior circulation has really minimal warning signs. So when you have TIAs, that's more related to the carotid disease. Posterior circulation, they're just going to kill you. So the posterior circulation, the subclavian, asymptomatic stenosis, all that, we just need to pay attention to that. And this is the patient problem. So he has occluded subclavian. You have a subclavian carotid bypass, and in a moment he lifts up his arm, this bypass is kinking. Cool? So we redo the bypass. We also put the stent in the, here you see in the vertebral, we have a calcified plaque. So we'll play this one more time. So this is a plaque in the origin of the vertebral. So we put the stent in here too. So we try to do everything we could, and guess what? He lift his arm up, he's still dizzy. So again, we try our best to, but again, when you think about this bypass graft, these are really softy. These are really not like a pipeline or metal thing. These are for lifting the arm up is really changing. And again, CT, MR, angio. How you do that? Patient's laying down with straight head and the arm down. Remember how we did the ultrasound? Nobody would believe you. So, we did an angio with the arm up. So here, you see the arm down. Here's your bypass. Here's your vertebral, and you see it's blue. That would be a normal flow. And suddenly when you have an arm up, you don't see too much flow in the vertebral, and that delay and the different color tells you that's a half a second delay in that vessel. And have you guys seen a color angio before? Thank you for coming. This is why you're here. So here color angio, and this is called the eye flow. So you're timing your contrast arrival too. So not just looking at your lumen, yeah, there's a narrowing there, there's a flow, but again, use the physiology, use the dynamics, not just to have a static imaging, but think about our body is not just like a 2D picture, but look at the whole dynamics behind all those blood vessels and all these symptoms. So going back to the ocular stroke piece, so how you detect these occluded vessels, we confirm it with angio. Because again, nobody will believe you. You need to have an angiographic confirmation that indeed that blood vessel is occluded. And this is how you see that this is an occluded MCA, and this is how it looks like on angio. Within like 30 minutes. So that's how you learn how to do that. AVM, remember, low PI. Same scale, and when you have an AVM, so this is an AP view, carotid, and here's a big nodus. So how you treat AVM, you just radiate it, and hopefully with 6 months or 12 months, hopefully by radiation you're able to shrink down, and hopefully it wouldn't rupture. So if someone ruptures, that's equal death. Oh, what's missing on this picture? Did you guys see skull? There's a skull right there behind you on the table. That's what's missing. So you see the white material. It's not there. Somebody eating it. Some ugly bacteria, and you see the bone is missing. Because you don't have a bone, you don't have a box, you don't have a resistance. So your flow becomes non-volatile. So again, going back to hemodynamics, if you print out a 3D bone and you put the bone back in place, hopefully it will close the skull and you're able to build up again the resistance what the brain needs. But otherwise, this is really ugly looking buffalo. So this is one of the craziest things. The same guy who built the TCD machine, Dr. Aslet, has this hemodynamics.com toy on the internet. Free of charge, you can play with it. Here, what I'm playing is, I'm compressing the carotid. And by compressing the carotid, I want you to see the waveform. The waveform is recorded in the middle of subartery here. One more time. I'm compressing with this finger. And that's your flow behind the carotid occlusion. Cool? So this is how you learn how the blood flow is changing. And this is in real time. Occluded carotid, open carotid. This is again, a patient had a 40-year-old ski or some kind of accident, injured his neck. And we said, when your headache is gone, come back and we'll rescan you. If you have a dissection, you just anticoagulate the patient and send them home on pill and come back in 6 months. Did they come back? Other idea we had that we're linking again the symptom. When change happens in your brain, and again, your headache is gone, come back. So he came back and he's recanalized spontaneously. And here's an occluded carotid, here's an open carotid. This is how the MR shows you the carotid occlusion. Here's the carotid open on the other side. So MR shows you a flow void. So I'm not advocating, yeah, I'm a radiologist and I love ultrasound, but you want to compare ultrasound to the other modalities. So you know how you detect occlusion on MR? Is this occluded or this is occluded? Do you guys know? The black hole is the open. Why? Because you spin and it moves, so it leaves the black hole. The spin and doesn't move, that's occlusion. Cool? So when you see a flow void here on MR, that's the open vessel. Just a reverse thinking. But this is how you need to see, yeah, this is occluded, this is open. I'm gonna leave some time for the hands-on. Let me see. Hey, beautiful. Pilot says, I have an occlusion on a CT, I have an occlusion on an MR, and the ultrasound says it's open. Which one would you believe? Ultrasound! Yes! Ultrasound always the best. Again, CT, MR done with straight head. When I do the ultrasound, I slightly turn the head. That slight turn was enough to open up that carotid. If he leaves his head straight, the carotid is occluded. He turns his head, think about it, he was a pilot and he was flying for like 12 years after the car accident. And again, we had to do an angio to confirm it, but the angio confirmed it with a straight head, occluded. Turn the head, open. So this is why it's kind of fun that you really want to play with the body position when you're doing these exams to really listen to those, that you can really find those occluded or open vessels. One big warning, if something is occluded, it's really hard to recanalize 6 months or more, because the recanalization sometimes just the vasa vasorum and the hypertrophic vessel wall, which is again feeding the wall. So it looks like on an angio, yeah, maybe I can stent this, no. Because this is just in the vessel wall. So the vessel wall, hypertrophic vasa vasorum looks like there's some angiographic material gets into the contrast distal. But again, and when you look at the ultrasound, looks like a stenosis or high resistance flow, but that's a difficult one. Barking dog, who likes dogs? Do you guys like dogs? Like that guy? That is a clot in the middle of the common carotid, and that is a clot causing this UWI lesion. And if you don't take it out, definitely will go up to the brain and give you even more trouble. So that is really interesting that ultrasound helps us to say why the stroke happened, and you really need to watch it all the way from the origin of the carotid, because if you see waveform changes, say, hey, go back when it was normal. So when you see something abnormal, you just want to go back when the last time you saw it normal. One more. I'm in Hungary. We are doing a stroke conference. I'm getting a call from Houston. Houston, we have a problem. It's like, oh, what's going on? 36-year-old lady overnight grows that clot in the carotid. Overnight. And you say, how is that possible? 36. I said, well, if this is here, it had to be there before. No, it wasn't there, the CT was normal. Would you believe? Never. You always want to look at yourself, and this was the normal CT. See that tiny? They just missed it. And again, we are human, we are missing it, but this is how you go back and you learn that that clot was growing, and definitely overnight it's really grown a lot. Well, what was stunning, this is how you're not going to miss it next time. So the 3D reconstruction shows you the indentation. Really interesting. So if you look at the 2D, say, hey, I missed it because it's a black and white, blah, blah, blah. But when you look at the 3D reconstruction, you see the indentation. Indentation. Cool? So that's when you're using your 3D, an idea how you not gonna miss it, hopefully the next time. So we did the surgery, and this is how it looked like on ultrasound. And sadly, during the middle of the surgery, she probably lost one of the clots from here, went up to the brain, and occluded the entire MCA. And this is how it looks like right before the surgery. Okay, and the last thing I want to teach, sorry. How many of you failed on an anatomy exam? I only failed 5 times. So this is why I learned anatomy so well. Did you guys know that the vertebral artery is originating from the carotid? You didn't? See? Common carotid, external, internal, and there's 2 vessels here. One is the basilar with the 2 PCAs, and this one is internal with MC and ACA. This is the only one hopefully you're going to see in your life, because again, it's not in the books. Not in the books. Huh?
Is it an anomaly?
Exactly. This is why they're not teaching you, but even my anatomy professor will fail on this one. I really want to go back to my medical school and ask a few questions, like a day back after all those failed tests. It's like, hey, what's the name of that vessel? You don't know and you're a professor? So, but you figure it out. Because this is on the surgical part, you have about 5 different ways to have the vertebral basilar originating from the carotid system. Otis and some others, trigeminal, but this is called a hypoglossal, because it's goes through the hypoglossal tunnel. So this is a persistent hypoglossal artery. You learned something new today. So you go back to your anatomy professor and ask them, you didn't know the vertebral originates from the carotid? And when we saw that one case, we thought that this is the one case in your life. Next week, here's another one when we stented, and you see it's coming here, foramen magnum, and we had a second case like they just found us. Anybody has a birthday? Birthday? No birthday?
All of.
Everybody has a birthday. Balloon. This is your birthday balloon. That's a nice aneurysm sitting in the distal M1. So this is the M2. Here's your balloon. What you gonna do? You're gonna coil it. So this is how it looks like on angio. Again, an AP view. Aneurysm coiled. And sadly, this is how it looks like on ultrasound, because one of the vessels occluded. You have DWI lesions on both sides. So this blue, see this blue branch coming out? So that is no longer there. Sometimes you do have those complications that you occlude some vessels, but again, it's more about the interesting that when you go through the arch, you may have some embolization just from that results this DWI lesion on both sides. So this is why we like to monitor procedures too, that you're trying to prevent any complication on the table while doing these cases. And I'm going to skip this one. Any questions? Do you guys like brain death? Do you want to talk about brain death or no? Okay, no brain death for you. You guys are too serious today.
I have any questions, but at the end of your presentation, Professor.
Okay. I need to show you my bubble. First, let me tease you with my OR. This is pretty cool. So, on the YouTube, if you search for 360 video, this is our OR, and with the mouse, you can rotate around our OR. Cool? And this is 10 years between. So this is 10 years ago. Look at the speed. So this is a 3D spin. And slow. Look at now. Less than 2 seconds. This is a 3D acquisition. So able to do complex cases. And the idea is You monitor the blood pressure, you monitor your ultrasound, and then you have your X-ray. And this way you have 4 channels video for education. Even if you're not in the room, you're able to replay this and learn from more about these cases, how you do them. And the bubble. Oh, sorry, one more thing. We are addicted to robots. I don't know if you guys like robots or not. This is our OR. We have 5 robots, and one of my robots is the brain. So it just sits on the head and finds the signal. And what it does is you put 2 of these white stickers on a patient head, and the robot with this area will automatically find the signal. This is pretty cool. So this is not the robot, by the way. This yellow thing is just looks like a Ferrari. That's the color. But this is how the robot looks like.
To get some flow back.
No. We're gonna skip those interventions. That's more important for anybody neurosurgeon? Neurosurgeon? And then I will show you how does it
They
work.
are
On the Zoom. Green room. Why? Because you see the red and the blood easier. Can you believe this? So they have a green light, so you can see, and this is what we are operating. You learn, this is black on MR, so it is open. Very good. This is not black, this is occluded. So this hypophysis tumor is already occluded 1 carotid, and I'm monitoring this other carotid. Meantime, it's almost in the lateral ventral. So this is the second operation. So this is when you cannot drink. If you're a neurosurgeon, you are really picking up through the nose that tumor. In the meantime, this is my carotid. This is, oh, sorry. So this is the carotid. You are next to the carotid, so you don't want a shaky hand or too much coffee in the morning, because definitely you're gonna trash that carotid. And this is what we monitor in the carotid. So this is just a little bit more motivation for scary cases, but this is, for example, a carotid body. Yesterday I arrived to the hotel and this was a call, hey Zsolt, we have a carotid body tumor, can you help us? So what we do, first we're creating an onyx cast, because it's a hypovascular tumor, so if you would take out the tumor first, it would be bloody mass. So you will glue the tumor, and this is how you see the tumor now. It's easy to retract and easy to take it out. And now you see hypovascular, look at all these blood vessels. So it looks like an extra carotid grows into the tumor. This is why it's so hypervascular. And I need to show you the bubbles and then we'll do some hands-on stuff. So bubble, why bubble is my favorite? It's because I like to this is my IV scale. So I'm starting an IV. In the background, my TC is already monitoring the blood flow. At least I'm wearing glove on one hand. You should wear gloves on both hands. Uh-oh. So this is a 6-inch extension I'm doing back under the blood, and my contrast is just saline. So the saline is the contrast for my ultrasound. So it's a cheap contrast. And what I'm looking for, is when you're a baby in your mama's belly, you're bypassing your lung, and the flow gets from your mama. So after you have this hole in the heart, and after you're born about a week, months later, you're supposed to close down this PFO. And 20% of the population open. If you have varicose veins, 60% chance that you have an open PFO. So I'm agitating between 9 cc saline, 1 cc air. Husband is a cameraman, doing an excellent job. Injection is in. Did you guys hear the bubbles? 2 seconds later, it's in the brain. Tells you that it's bypassed through the hole and went to the arterial side. You're injecting something into the vein, shows up on arterial side. Got it? And this is how it looks looks like those white lines when the bubbles or something arrive to the brain. Questions? Before I show you more stuff, because I do have more stuff. But. Okay, one more fun. So the bubbles, when you look at the saline, there are different salines. So you see this is a good one, this is a bad one. And this says preservative free, so that's the bad one. This one is red, it says not to use a newborn. Why? There's alcohol in it. So, when you have alcohol in it, it's better bubble. So this is the red label, this is how you remember. All alcohol already, come on, wait until you graduate. So, the point is that 2 minutes, this is the same patient. Same patient, 2 minutes apart, 2 different injections. This is what scares me. So how important is it? What's your protocol? Where do you inject? You're in the sitting position. All that becomes really important because if you can make that much difference, just what you're injecting, this is when you need to really stick to your protocol. I'm using the same needle. I'm using this pink needle. You notice it was matching the lady's dress, so that was pink too. But the lower lock, so make sure you can tie the syringe to the stopcock, otherwise it just flies off when you're injecting. So that's kind of cool. Okay, now I'm ready for questions. I don't want to scare you with more stuff. Questions, please.
Do you have any questions? No?
Let's see on the Zoom. I have one question. How long does a normal Transcranial Doppler take? How much cost? Dude, you want to know the cost already? You don't even know how to do them? That's not fair. If you are in Los Angeles, you are getting a bill for a TCD about $2,000, and insurance pays about $400 or $500. If you're in Houston, we charge about $1,000 and we collect about $250. So about $300 was the reimbursement is for a TCD. But you have 4 codes. So each of those 4 codes, so 300 per se. And when you're new to do a TCD, I would say it takes about 30-40 minutes. When you're a pro, I have patients lines up every 10 minutes in a private clinic. When you're working per hour, you do it slowly, it takes an hour. But when you're in a private clinic, chop chop, it's 10 minutes. And there's, oh, amazing. Thank you for the heart. And what I also did, we are going to share, I have a really cool collection, guys, on the website. We shared this, we collected all the videos. So what I wanted to show you is we do like an annual workshop, and this is like 4 or 5 hours, like an entire conference on the YouTube, or these other ones just like hour-long lectures. But you have all these, and Dariana will share that with you, or we'll share that piece. But also another thing that if you go to a YouTube, I just want to show you really fast. We have a really gorgeous channel. It's called Debaki Education. And we have CV education. So it doesn't matter if you are a vascular surgeon, cardiothoracic surgeon, cardiologist, or anesthesia, you will find your playlist. And basically these are entire conferences and a bunch of videos. So I think one of the parts what we try to do here in education, how to do things, how to do a carotid ultrasound. So for example, I have a carotid protocol there. or how to do amputation. That became my favorite video. I don't know, is the physician visiting it or some people who really want to see blood and they say, hey, I want to see the amputation video one more time. But that's #1 visited video on our website. So amputation, check it out. But so we have this imaging, multimodality imaging. So we do have cardiac MR, all the fancy stuff, and a bunch of these other videos. I would kind of recommend for you guys to rewatch those as well. Yes.
Okay, thank you. I hope that my French students understand English, but if no, please put your question in French. This purpose, professor of our lab, and you are involved by our university and by myself. You are in contact with the University of Semmelweis University from Budapest. We are close together. But the purpose of this lab is in fact a practice of my department, of myself, department cardiac surgery, to connect the very best places from the world in one topic. Your field in ultrasound is the present, is the now, but is the future, because you present very nice the role of physiological diagnosis, not of statical diagnosis. And I mentioned you can put on your screen the high resistance flow and low resistance flow if you find very quickly this one. Why? And we are connected with the, I work too in the military hospital in Bucharest as a cardiovascular surgeon. We are connected from here with this from Arad, with military hospital, and you practice too. You are connected in USA with military department. We are connected with Debrecen, with my and our alma mater. And if we can, we join just for a few seconds this August at the clinic from Debrecen. And we are connected too with private hospital, for my private practice, near Bucharest, but this is surprise. For instance, I give not the name because it's in construction. And if you have, yes, for example, in cardiovascular surgery, now coronary with our workplaces in Debrecen and my minimally invasive practice, I think it's 1 year I take it from not classical coronary bypass surgery. Why? Because are you from Houston, my colleague from here, and for example, my colleague from Debrecen put 2 or 3 stents in the coronary arteries. And it's one, the interventricular anterior descending artery, it's closed and can be opened by interventional procedure. I put a mammary artery with endoscope, harvested with endoscope, and I put in through an off-pump bypass. This name is MIDCAP, minimally invasive direct coronary bypass. I harvest the internal mammary artery and I put on the coronary artery on the beating heart. And I call Professor Garami, please help me to see I can perform a coronarography, but please help me because the patient is here in Arad. I have my co-worker, for example, Rebecca, please go at home, the patient, and please check if the mammary artery, the graft, is patent or not patent. Okay, we connect to Zoom to anything, Houston, and with our device performed by gift by contact corporation. And if you looked the internal mammary artery on this original place, it's a high resistance flow. And if you put in the intercostal space on the graft, you can see the same flow, but low resistance flow. Here, because the coronary vascular pathway, it's a low resistance. You can look and can prove that the flow in the mammary artery is patterned or not. To this coronary flow presented by Professor Garami.
So this is why the subclavian stenosis becomes really important, because when you're planning your Lima bypass, you want to know if there's a blood pressure difference between the two arms, more than 20, you're suspicious that you have a subclavian stenosis. So this is sometimes not just ultrasound, but start with pulse, blood pressure, and then ultrasound will help you. And these are the crazy waveform what you see when you have a steal in the subclavian. And that's where is, I would say, here's your Lima, here's your vertebral. They are so close. One goes to the brain, one goes to the heart. Cool? Watch the angio one more time.
And if you have a steal phenomenon.
See that? So the Lima was feeding, stealing the flow from the brain. So one more time. Do you see the difference? Come on, he's from glass. You can see it through him. Do you see the picture? So you see the Lima is feeding the heart and is stealing from the brain because you have a stenosis in the subclavian. Got it? So because a contrast goes into the Lima first. That is feeding your coronaries. That's a cool confirmation. A surprise that your patient is dizzy now because now it's feeding the heart from the brain. So with the stenosis, you want to fix it.
Yeah. I have a question. So you mentioned earlier, I think you were talking about the MTA. You said the patient had a restenosis after 2 weeks, even though there was an intervention with a stent. Is there a possibility to re-intervene and to fix that? Like, have you seen it happen before, or is it something that's going to be constantly reoccurring?
So that time with the second stent remain open, the secret was that it was a drug-eluted stent. So again, I think that this lesson, what we need to learn, that if you stent someone, you need to have Plavix on board, antiplatelet stuff. Second, that you want to treat what's causing that restenosis. So restenosis meaning that you have inflammation in the body somewhere. So that's a moya diagnosis, really rare. I don't think you're going to see it too much here. It's more in the Asian population, Indian population, but so in Europe is quite rare. But I heard some case report even in Hungary on a stroke meeting that they had the moya disease, and the moya in this 32-year-old lady was coming from infection from uterus. So hysterectomy was the treatment. Hysterectomy, no more restenosis, she's fine. It's really crazy that again, OB/GYN surgery fixed your brain. But again, that's why I think the body is really complex. Circulation is the same, whatever shit you created here is still reaching the brain and finds it. And this is why I think about the PFO. Why the PFO is really important. So PFO, we found it with people with lots of headaches. So what would be your thesis? Why would you get headache if you have a PFO? I want 3 answers at least. You're on an exam. I want to hear 3 reasons why you have headaches.
You have a slide, you presented a slide with an anatomy of carotid artery. My first operation in Bucharest was not a cardiac procedure, it was a vascular for a tumor, paraganglioma in the bifurcation of the carotid artery. And I am by formation, I am anatomist. And we looked at the angiogram, it's okay. Why? Because we look if you have any branches on the internal carotid artery. Normally, is described internal carotid artery as they are not branches on internal carotid artery. We performed the operation in the private practice. It was the first operation, and we performed to the tunnel, minimally invasive. The tumor was expanded below the skills. Exactly, it was necessary to prepare. But I am convinced that it's not, there are not branches. Here was an anatomical variation. The ascendens pharyngeal artery was originated from internal carotid artery. That anatomy is a rule, but not every time. For the bleeding, we controlled this bleeding. It was a happy end, but sometimes ultrasound and Doppler can help you because you have more position that angiogram that is statical picture.
So the other thing about the ascending pharyngeal, while we're talking about it, the ascending pharyngeal, we had a case when we thought it was a dissection. Because the ascending pharyngeal, when it originates from IC, runs parallel with IC.
Parallel with IC.
And this is why it looks like a dissection. And that's another interesting scenario that you want to exclude that, make sure you understand the anatomy. I don't think I've been able to find it, but that's...
You can see how thin it's the bone here. It's
Right
a
there,
principle of
this is where
ultrasound.
yeah.
It's a human
Yep.
cranial surface, how thin it's here, and for this both can be checked and can be used
Oh,
for.
yes. I wanted to do one more motivation for you guys. My keyboard is... This is strange. Do you guys know how to fix a keyboard which is locked?
Have you got one?
Yeah. So we're going to type in telemedicine and we'll take that out.
There is an option to add a keyboard here. Also, one of the I have a question potentially.
Yeah, it doesn't do it. Yeah, see, it doesn't do it.
Even
Yeah, but check it. Oh, that's it.
so you can do that. Yeah, okay, we'll go about the headache with the atrial
Yeah,
films.
I'm ready.
Could it be something to do with with it being deoxygenized blood?
No,
Would that fit in hypertension?
no.
So that's two answers. Anybody go first?
I was thinking of a very it's like a stealing phenomenon for condition.
And
And it was well known to the
I give you guys a clue when I said your varicose veins 60%. Clot in the leg veins. Cross the PFO, goes to the brain. One. Second, that you are like the PFO has a membrane and locally snaps and holds the clot formation. Number two. And my favorite is you have the blood pressure angiotensin system. Generates a molecule in your liver. Needs to go through the lung to be activated and the angiotensin. you skipping the lung activation. So you have a treasure sheet enzyme making your headache non-stop. So that's my for today. So finally, I just want to motivate you with this piece. Not with the music, but after that. Yeah, let's do some shopping.
Well, the Methodist folks approached us with the goal to use some of the technology that we're proving out both on the ground and in space for having the robot help with human perform tasks. In this case, medical tasks with both ultrasound and injections as part of the ultrasound procedure. You're welcome after this.
After training lots of quarters of position, I programmed electric bishop to train the program. I would say that within an hour, I trained him more than what other students are working for a week. So I think that he's learning really fast. So our plan is to really use Moderator as a telemedicine doctor. So we prepare it, and we hope that the robots in the future telemedicine able to perform medical procedures directly by expertise or even doing the procedure by itself.
Every time we perform a new task, looking at our experience, that leads to us developing new techniques, and that can only be used for medical industry, but other industries where NASA can provide help throughout the American West.
So I hope you guys noticed this is the same thing what the robot was using.
The chief executive
That gray ultrasound, which is ready right there, that is the same ultrasound machine robot was playing with. Yes, I heard someone from Debrecen would like to talk to us.
Yes, Jerry,
Hello, Freddy.
you can.
Yeah, he doesn't have the camera on. Meantime, any other question?
Dr. Jury is in
So,
procedure in the cath lab from Augusta. And
One more question. Does a TCD has a minimal side effect after use? Yeah, if you leave it on for a long time and your person is dead and you're not cooling off the blood, you may be burned because ultrasound is like a microwave. So if you leave the ultrasound on for 2 days on a dead person, you may burn something. But it's a late side effect, so it doesn't count anymore. But seriously, it's ultrasound decrease the power when you go through the eye to 10%, so make sure you're not boiling the eyeball. Because then you drink a tea or boiled egg, not good for breakfast. And there was a question about having specialized courses and workshop. Well, I just showed a bunch of YouTube videos. December 2nd, we have an annual meeting. You guys can register. Vascular Ultrasound Master Class, that's the name. And you will find it. That's the same on the YouTube. If you just search my last name, you will find all those videos. Okay.
yes, I don't know, I
It might be in the procedure.
it's in a procedure. Dr. Jury sent you from.
Thank you. Yeah. Well, he helped me out with one of my friends. Okay, here's, he helped me with some cases when you need to find a doctor who was closer between what are they at and Debrecen, because I think he works in both places.
Yes, we was in a project with Oralia.
Yep.
And yeah.
So what we want to do, if you guys remain on Zoom, we're not going to close down the Zoom. We're going to move the camera closer to the machine And we want to show the real hands-on how does this machine work. So this will be the hands-on part. Any other questions? Okay. És akkor valaki, I want to volunteer. Yeah. So in my private clinic, actually, this is my setup. So I can do the carotid and the brain in one setting, and the reason for that, the carotid doesn't end up in the jaw. The carotid goes up to the brain, and that's why it's a combination of two different tests. So remember, slightly turn the head. So that's how I was showing you a few cases. Can you find me some paper towels so we can put them in the bag?
Should have used this.
Sorry.
That's fine.
This is just a version here. So, first, cross-section carotid. My marker is in the middle. And you see his carotid. And the idea, what I'm trying to do is, see my hand is really stable, holding it almost like a pen. And I want to keep the carotid always in the middle. Cool, nice thyroid. I want you guys to check your thyroid before you start to work in radiation and cath labs. Then you see how it becomes like spongy and how your thyroid becomes diseased. So here's a cross section. Here's a bifurcation. Who's dividing it into two pieces. Then I turn longitudinal, and here's my long view. And what I'm trying to do is, so one end to another end, both of them is lines up like this. Cool. Using the sternocleidos muscle as my holder for the probe. So if I do this, no good. If I do this, no good. What I want to see is the twisting each end of the probe, and you line up the vessel like this. Cool? So I'm going to leave both of these machines here until like April. So when you guys coming into Dr. Galajda's lab, just you able to practice on these. And one more, really simple. So this is why it's developed for the army, that you put a color on, and the changes are really minimal what you are doing here. So when you're doing on 2D, you can increase the gain here on the left side. So it's too bright, that's not good. You want to keep the nice contrast, something like this. And you go up and down on the carotid, and you see the bifurcation here. Cool? So after you did the common, I'm just going deeper. So here's the process, and here's your vertebral. Cool? Did you guys see? So I'm in a common, beautiful common, and I'm using the sternocleidos muscle as a target, I'm rotating my probe, and I see the transfer process almost like arcades. And between the arcades, this is when your vertebral is going to run. If he has a vertebral. I hope he has a vertebral. Yes, yes. So the other hint is really interesting when you see his vertebral and the color. So the blue is your vein, red is your artery. So that's another cool way to see that the carotid artery and the vein on the IJ or the vertebral artery and the vein goes opposite direction. So this again, you see the blue is your vein, the red is your artery. And when you give too much gain, see this is too much gain. You come back and you want to just show the result. Cool. So one more time, long carotid and the vertebral rotating. The last part, that's how you measure velocity on this baby. You push Doppler. And when you push Doppler again, you want to angle it this way, the way it runs. So you have straight right or left angle, and you push a Doppler one more time after you position it, and here's your Doppler. Okay, so any cardiologist?
There's like 5 or 6 in the room.
Did you hear that? So he has a longer pulse here. So he is again maybe stressed, but again or a little bit of irregular heartbeat. You noticed.
Maybe it's physiological.
Breathing.
Yes.
Very good.
Breathing.
because it's not AFib for sure, but just the distance, you can kind of peek it even from the end of the room, that there's a distance between these two beats versus this one. Cool. So this is the extracranial. So again, you can go as proximal as you want. This is your innominate and subclavian here. So that's how you can pick up the vertebral origin. So this is your subclavian vert origin. And then you come back and do a long. So that would be my carotid vertebral. And my protocol is like five measurements: common, bulb, internal, external vert. So that's the 5. In certain protocol, if you really want to have like a credentialing, they're asking 3 in the common, 3 in the internal, like proximal, mid, distal, internal, proximal, mid, distal in the common. I just think that's too much. So when you want to do, even if you see disease, there's no reason for that. So here's my other baby, and I just want to show you the MCA first. So this is again a 2 megahertz, 2 megahertz probe, and it's 1 crystal. So when you just put the gel on it, keep watching the screen, so at least you see what I'm doing. So anything is red coming towards you, and a blue is going to be the ACA. Yeah, see that? You really have some irregular heartbeat. Sorry, your life is open book now, man. You will look there. No, we know that you need a new heart, all that. So with a mouse, my left mouse click circles between, see how when it's green? So I, using the full power, and I'm able to change the depth with the scrolling. So this is the middle cerebral artery in the middle. Oh, do you want to bring the, yeah, you see the camera. So this is the proximal. I will go to the middle. And this is why I wrote that 3D printout, because when I go distal, see how much my hand is angling more out? And you see the M2, it's a smaller end of the MC, this is why the velocity drops. So this is distal, this is proximal. So this is the angle, but my hand is really stable. So after I found this hole, when I can look at this flow, I did not change my hand at all. On a protocol, I would do 3 measurements in MCA, proximal, 60, 50, 40, and I would do an ACA. This is my ACA. And then from ACA, I would go posteriorly for my PCA. Hopefully you have a PCA, and here's your PCA. So here's a red, a little bit of PCA. Put more gain on, too much gain. You hear the sound of it? What's your circulation? So because the vertebral band is so much smaller vessel than your MC and the carotid system. Okay? My favorite is again a vertebral basilar. And I don't know if you guys like Chinese food. You will like it from now, because your favorite Chinese food is qing dong. Qing dong. So you put your qing dong, and when you put your qing dong, your vertebral basilar, that 150 angle, suddenly will straighten out, and you see the whole vertebral basilar in one line. So putting your chin down, I'm putting just the process here, and then I let it go. And I hope to see some blue. So red is my extracranial vertebral, or in this case probably a vein. See that non-positive flow pattern? Vein, CSF, something. Blue, blue, blue would be my preference for the vertebral basilar.
So this is a vertebral, a depth of 60. So from my measurement point, what I'm doing is, I'm kind of remember where I'm sticking. This is why I didn't clean it. So you guys will able to practice on his head. Sticking it and pointing it to the nose bridge. It's almost like you know the location and where to point, and I want to see this blue. And if you go a little bit deeper, you're going to be able to see the basilar at 80 and a 90 and 100.
Sometimes we use the suboccipital triangle to put a bypass. And I have a patient with Takayashu that have a bypass from the left subclavian artery, the saphenous graft, because all was occluded here in the suboccipital triangle to the vertebral artery. And she is okay.
So you're going to visit your cardiologist friend for sure, my friend, because definitely the irregular heartbeat is there. But what you notice is the basilar is so much faster. So his vertebral on the right is really small. So this is a hypoplastic vertebral. See that? This is another anatomic variation. Small vessel, velocity-wise, barely doing anything. And when you go to the basilar, the other vertebral comes in and give you a nice flow. Cool? So this is the two-piece I want you guys to practice. We're going to leave the eye alone for that purpose because it's a safety. And just really fast, I'm going to show you how I'm doing it. Keep your head straight. I'm going to decrease the straight. Decrease the power to 10. And I'm barely holding the probe. Close your eyes. Holding the probe with the 15 degrees lateral. Show the ophthalmic. You can hear how high resistance again this is. The fancy regular stuff. So, but this is how fast. So if you have 4 seconds on the screen, there's no reason I should sit longer. I capture it, save it, picture, done. So when you push save, that takes a picture. If you push record, it records until it's on. So you don't want to push record. And when you save a picture to a USB, you can export it if you see some fancy stuff and you want to create some pretty slides.
Can I wipe my hands?
No, you cannot. I'm wiping. So this is one of the polite way that I'm wiping first because I see it. You don't see it where it is. So let me clean it first. Then I'm handing you a towel when you feel like, but you're still not opening it yet. Clean your eyes now. So heavy water or something, there's not much chemical in the jello, but again, if it gets into your eye, a little bit uncomfortable because again, something. I didn't put any glue in it, so hopefully it's still really open and you can still open it. So what I want you to guys, just rotate, practice for me with the full power. Give me some few MCAs like this. And another person can help with the mouse to change the depth and able to take some pictures. And you push the roller, that takes the picture. When you see letter M, that's taking pictures. M, save. And with the roller, you go and change it up like this. And when you come in, like do like 2 people practice on each other. You can practice on yourself if you're really selfish. But use your friend. Okay? Stay. Who is first? So one of the crazy things is, I already see the problem with his hand. So one of the problem is that your MCA is going this way. So when you point straight, the bone kind of narrows to the front and you point posterior. So you want to point anteriorly and up. Something like this. And I I swear, it's really easy to do, man. I just want you to have a feeling.
The problem maybe is the gel.
Very good. Blame it on the gel, not on the skin, but here's the picture. Very good. And after you see a little bit of signal, then don't move. So then you just rotate. Blame it on the gel. So we'll fix your hair, man. It's got to be nice and white when you're done, because when the powder becomes dry, it's going to be nice and white. So one thing is important, that you don't go in front of the tragus, because then you're a dentist. Because then you will see the dental arteries and stuff, and that's high resistance. So if you want to stay with the brain, that you stay about nice. So your left hand, grab that baby, hit the mouse twice, and roll it. Yeah! Now we have a master in the room. How does it feel, sir, to perform your first TCD?
A little bit hard in the first time, but now
Getting
I think
coffee.
I'm mastering it.
Yes. So, and then you remember the second move, that proximal is going up. So from proximal to distal, you're moving up like this. So that's again another move that you're learning. To be able to follow the MCA from proximal to distal, you were kind of pointing out. It's okay. So that's when you move too much, you jump over the vessel. Remember, it's 2 millimeters in size, so it's a really small vessel. You're sampling about 9 millimeters. So if this is your vessel, you're sampling about this big. But if you move fast, then you're still jumping over that vessel. Nice. Those blue are ACAs or PCA, because you're
Yes.
straight again. So that could be PC as well, because you're pulling straight. Nice. And when you're really in the middle of the vessel, you're going to be nice and strong signal. But that's the big one. And then you don't move. After you have this one, you just hold it still and you angle up a little bit. Don't lose it. Good. See, the velocity is lower, that means that you're in a branch too. So that's always the highest velocity, your MCA. Now you're getting back into the M1. Nice, pointing up to like this. Nice. See how the red is sneaking out distal? And your signal is stronger. So this is how you're, and also you need a little bit more push. Because if you don't push it, that you have moves on the skin, but also between the skin and the bone, the fat. You want to push it to the side, because that's again resistance for your ultrasound. Good job. Next. Rebecca, vertebral, right now. Chin down. Your favorite Chinese food? Chin gong. And you want to point to the nose bridge. So here, but you point to the nose bridge.
It's really liked by
Push it
us vascular surgeon, this place, because it's the less possibility to put a bypass on this vessel.
Yeah. Okay, and you're going to see some blue. See the blue at 40? No, hold it. I had enough of those holding. Just trying to, see that blue?
So you want to follow that view up in the middle. And while you're doing that, on the left hand, you will change. Cool. So that's the vertigo now. And by scrolling it, whenever it's green, then you can scroll and change the depth. Left mouse click, we'll get to the depth. Left mouse click,
À gauche.
left mouse click.
Poussez gauche. Gauche.
One more time.
Sur le mouse.
And now you scroll. The middle scroll.
Non, utilisez
Cut away. Cool. Good. And this is at 40, but I want to see it at 60 and all the way to 80. See that at 70, the blue? One more time. Scroll down. Scroll down. No. The middle, the depth. The left mouse click, left mouse click, left mouse click, left mouse click is circled. Okay, stop and scroll down. Yeah. And all the way to 70. And you will see the camera. So don't go too down now, just stay up in the bottom. So that's I don't know what happened to his vertigo. I should have taken.
It probably doesn't exist.
I think maybe your chin down. Put your more chin down. So maybe he didn't drink enough Chinese soup. Hold this quick. So that's blue. And just turn it. Got it? See the blue? Hold it and get hold this really still when you see the blue. Well, vertical bands is a little challenging, I would say. So this is why let's start with the MCAs. So here the secret is that I feel the bone, and when I felt the bone pointing to the nose bridge, I need to grab, and maybe I'm pushing stronger, but that's the blue I need to see. Cool? Nose bridge.
With this transducer can be detected crystals leaving the
One crystal, yeah, because
diseased
exactly. So this one will be monitoring because anything else traveling in your bloodstream give you a different signal. So your red blood cells are flat. That's the signal what you're going to get from red blood cells. Anything else travel, the air bubbles or the blood clots or any calcified stuff from the valve, there will be a high pitch signal, high intensity signal or high frequency signal is what you're going to see on that.
It's very interesting during the extracorporeal circulation for blood bubble distension.
Let me see it first. So we are here, front of the ear. Okay. I'm sorry? MC is red and AC is blue. So we're going to see red here. An angle anteriorly and up like this. centrally and up.
Well, you made it look easy.
I know, it's not my first time, remember though. See that red? Change the gap. One more time. Scroll up. Disappeared the tongue, just rolled up. Okay, so one more time. Let me do it. Just and watch me. I don't know.
Yes, professor, it's 20 years experience, no?
I know it's more than 20.
More than 20.
So
First you find it with ammo, right?
yes, so I'm looking at my ammo, but what I'm scared of is like I don't know, is really the jello is not enough as you said, or what's the deal? But I'm going back to the same spot. And sometimes it's so easy to, yeah. It's there. I'm making a mark, I'm pushing hard, so next time you guys come, he has a nice dent on the forehead. You just need to put it there. Yeah, it's there, for sure. But see, what I'm doing is when I see it's not optimal, slightly, like I'm thinking about moving, almost like I'm not even moving, just thinking about moving. That tiny shakiness in my hand is enough to optimize it even better. And don't be afraid to push until he says, ow. When he says, ow, then don't push more. Okay, so I have a spot. Do you guys see it?
Yeah.
So a little bit front of the ear, and that's the dent. Right there. Higher. Too much angle. Come back a little bit.
Professor, you expect to present Târgu Mureș to
End of April, I think there's a
April.
student.
It's my alma mater.
Oh, so there's two conferences back to back in 1 week, so I'm
Yes.
staying for the whole week. There will be student, and also I'm going to try to do the same workshop.
Is it my
So
reasons?
what was funny, I did a PFO test on one of the volunteers. It was a neurologist from Chixa, and he had a positive bubble test.
Okay.
So I have a gorgeous video. Yeah, beautiful. So this is when you optimize and just think about moving your hand a little bit on the skin itself, like this, almost like a circle. Go back to the other spot. So you see how like losing it and come back to more. Okay, and point more down because you see it's 40. If you point down more like this, then you will get more right. And with the left hand, 2 clicks. Yeah, that one, 2. Up. Good. And the envelope, this is what it means in tracing the signal. The envelope. So your envelope gives you the number. So the number on the right hand side is coming from the envelope tracing. And you want to practice on young people first. When we're getting 65, 70, it's harder to go through the bone, especially ladies with osteoporosis. So guys, easier to do in the older age, but ladies a little bit more challenging. That was good. I saw the 60. Yeah, pointing down, you saw him getting the red, the M mode down to 60 because he's pointing down.
Pretty good. Good job. Next.
Can I try that?
Yeah.
Back.
Yeah, you will. That was enough. That was enough for
The
the
right knee.
No, luckily no. Well, we're working on
Will
that.
be-
I'm sure sooner or later, so for example, myasthenia gravis. So when you have testing functional TCD, closing the eyes, opening the eyes, and you monitor the PCA. Genius. So demyelinarization will show up that you have a delay of the flow getting into your PCA and just opening the eye, closing the eye. That's where you see the flow difference. Some guys in Portugal, they already think about the functional TCD of recognizing the millisecond the speech pattern, talking or something similar like a functional MRI, that you monitor the MC and you ask some tasks to do, so you're able to see the functionality.
In 1994 or 5, I worked in the department of Professor
Go deeper because you're not in the brain. So brain is about 50. Yeah, you're listening.
in a private practice in the clinic of Professor Evenimentului is they invented the procedure for switch operation, and we used for detection of bubble and for bubble during extracorporeal circulation electroencephalogram at this time.
Yeah, it's not being a life for sure. That's for
That
sure.
was 1994. Now we are in 2023.
So EEG is going to help us. Probably it's a better lie detector test than
But
anything.
combined, eventually,
You can do
in real time.
So let me sit down and let me show you what. So you can combine because the filters are the same. So maybe it's so angle, and put it there, and I want to see you at 60.
So is this normally done bilaterally as well?
It's bilateral because you're doing it both sides. I'm just doing the right side because the camera is on the right and the paper is on the right. But you need to complete both sides. But I'm doing right vert to basilar from this side because then I need to do only the left vert from the other side. I swear, I get it from all right.
Professor, your training was recorded because here in university, if anything is, you can recall your presentation. And
Yeah. So start to see that's my blue. Yeah, I'm listening.
And yes, thank you for the University of Debrecen to help us for this meeting. Thank you more, Professor Garami, for coming here. And I think during techniques and internet we can be close to you, to Houston. It's very nice to be close to more institutions in the world. And I hope that this lab will be a good training place for our students, residents from the hospital. And see you back, Professor. Nice to have you here. And thank you for participation. And,
Thank you guys for coming. Thank you. And you can still practice on